Hello, my name is Nii Armah Adu-Aryee, and I'd like to introduce you to a series of videos which will help you as medical students and perhaps for postgraduates who need the help with practicing whatever examination skills you have taught. These videos will only supplement whatever practice that you may have been taught by your tutors and will help you improve your skills. They do not replace whatever you have been taught. As a matter of introduction, before you touch any patient, you would probably have taken a history from this patient. Now remember that as a student or as a doctor in your practice, one of the most important things is to be polite to your patient. You will have to treat your patient with dignity and with respect, or else they will not like you and you will not get the amount of information which you require from them. The histories we usually take from our patients are designed to give us information based on which we will examine these patients, and whatever information we get from these, we will also go ahead to add specific tests which will help us to make a diagnosis and to plan our treatment. Generally, our histories involve listening to our patients' initial complaint, which we tend to term as the presenting complaint from these patients. We then tend to ask them to give us these presenting complaints in their own words, and we record them as such in the words of the patient. We proceed from there to let the patient tell us what happened, and we do this in chronological order. For example, I have abdominal pain and I have been vomiting. And your question would be, which one of them came first? And he will tell you that maybe he's been vomiting for the past 3 days, then followed by the onset of abdominal pain. Or the reverse may hold. He may have had pain in the abdomen for the past 5 years and only yesterday he started vomiting. So the sequence of events does matter, as they may point to different things. Now, after taking your history of presenting complaints, you may find that you are aware of other conditions which may sort of help you to make a definitive diagnosis. So you may probe a little further and get a lot more information which you may fit into the history of this presenting complaint. We are generally also taught in our lectures to then, after doing a history of presenting complaint, to go into a systemic inquiry, which then tends to support or refute some of the things which are going on in our minds. By the end of all of these things, we may then have a fair idea what we think is wrong with this patient. Then do we think that this is something that is a result of neglect, or something that is long-standing, or something that has precedent history? Maybe there's something in his family history. So we would like to ask our patient about his past medical history, which may give pointers as to what is going on. We may also find out from this past medical history the sequence of events that led to the current condition. We may also find out from the patient about his family history, which might point, for example, in a sickle cell disease patient or in a patient with breast cancer, what may be going wrong with this patient. Having said all of these, would all of what has been going on be drug-induced? For example, a patient with severe epigastric pain may have been taking non-steroidal anti-inflammatory drugs, and we may get this history from the drugs which the patient may have been taking. And in addition to all of this, it's quite important to make sure we know about the social standing of the patient, the work the patient does, because, for example, you may find an anemic patient who is a farmer who's been walking barefooted and has developed some worm infestation which is giving him anemia. So we put all of these things together and we make a subjective diagnosis, which we tend to call a list of differentials. Now, having made this list of differential diagnoses, we will then proceed to examine the patient. The purpose of this series of videos is to take you through some of these examination techniques and help you to hone them on your own and to get better and better with these examination techniques as we go ahead. The examination of the surgical patient is no different from the examination of any other patient. The emphasis just differs because of the different pathologies that we see. Like in every other specialty, it begins with watching your patient as they walk into the room. And you will probably notice that the patient has a particular gait. They may not be able to sit on the chair properly, suggesting that they have a problem with their anal part or their rectal part. They may, for example, be fidgeting a lot, which may suggest to you that they have a problem with their thyroid function. They may look pale, and they may have several other features. They may have freckles, they may have swellings on their skin suggestive of multiple lipomas, and all of these you should take in as you look at your patient without staring at your patient and making them feel uncomfortable. It is important that you make your patient feel as comfortable as is possible, and you should be as polite as is possible to your patient. At any time you need to examine a female patient, it's in your own interest that you look for a chaperone, because some actions may be mistaken to mean the other things, and you may get into trouble. So it is always very good practice to have a female chaperone with you when you examine a female patient, to make sure you do the right thing and that you do not get into any kinds of trouble. The next series of videos which we are going to show you will show you specific examples of examination of things which are fairly superficial. They will show you how we examine superficial swellings like lipomata, how we examine swellings of the breast, of the thyroid gland, and how we try and access additional information to help us make a diagnosis based on our findings. We shall add these bits of information which we have acquired to our history to hone down and narrow down the diagnosis that we have made. In addition to observing your patient as they walk in, it's important to position your patient properly to make sure that you can find whatever information you are looking at. And a different series of positions will be demonstrated to you in the various videos which you will be watching in the different sections of this compilation. But it is important that you always do a full general examination, as this will give you a lot of information which you will need to make your definitive diagnosis and other ancillary diagnosis at the end of your full history taking and examination. So it is important, as you were taught in internal medicine and in other fields, to remember to examine your patient properly, looking for pallor, looking for jaundice, looking at their pulse rates, looking for lymph nodes, looking at their palms, and looking for other general bits and pieces that will help you in making your final diagnosis.